Yes. Doc,
Wonderful.
uh,
All right, should I go ahead?
yes. Can I just
All
start?
right. So my apologies, I got the time of my presentation wrong, so I apologize for altering the order here. I'll be speaking to you today about efficacy of Metreleptin treatment in patients with generalized lipodystrophy before versus after the onset of significant metabolic disease. So Metreleptin for these studies was donated by several pharmaceutical companies. So I want to just start by going through some natural history of generalized lipodystrophy without metreleptin treatment. So this was a study headed up by Barish Akinja, who we just heard from, that included 81 metreleptin naive patients with generalized lipodystrophy. Among these individuals, the age at first symptoms was around 9 years with quite a big variability. And these patients had a very high lifetime prevalence of complications of lipodystrophy. So with respect to glucose metabolism, 58% had a diagnosis of diabetes or insulin resistance. Over 40% had an A1C in the diabetic range at least 6.5%. And more than a third had inadequately controlled diabetes with A1Cs greater than 8.5%. With respect to lipid metabolism, more than 80% had elevated triglycerides over 150 milligrams per deciliter, and more than half had triglycerides over 500 milligrams per deciliter, placing them at risk for acute pancreatitis. And almost 10% had, in fact, had a lifetime history of pancreatitis. These patients also had quite prevalent liver disease, with the majority having elevations in ALT and AST. More than 2/3 had evidence of hepatic steatosis, and 6% had cirrhosis. An important thing to understand about these complications in patients with generalized lipodystrophy is that they're progressive over time. And you can see this illustrated in the survival curves to the right that are showing the progression of diabetes or insulin resistance, organ abnormalities, disease progression, and survival in patients with generalized lipodystrophy, shown in black, compared to those with partial lipodystrophy, shown in gray. A diagnosis of diabetes or insulin resistance occurred about 12 years after the initial diagnosis of generalized lipodystrophy, and the first organ abnormality about 8 years after the development of generalized lipodystrophy, with an overall time to disease progression of about 8 years. And mortality in patients with generalized lipodystrophy occurred at a mean age of about 50 years. So we know that in patients with generalized lipodystrophy who are treated with metreleptin, that there are clinically significant reductions in metabolic derangements, including dyslipidemia and hyperglycemia. Here we can see data from an open label study of metreleptin treatment in patients with generalized lipodystrophy, showing a very large reduction in triglycerides, almost 900 milligrams per deciliter, a 1.4% reduction in hemoglobin A1C, and a 2.1 millimole per liter reduction in fasting plasma glucose. But it's important to understand that the patients who participated in this study were eligible for the study because they had significant metabolic derangements at baseline. And one of the unknowns that we have in prescribing metreleptin after its approval is when is the optimal time to start? Should we wait until patients have developed clinically significant metabolic abnormalities, or is there some advantage to starting it before those metabolic abnormalities have developed? So most of the patients, as I mentioned, participating in metreleptin studies had fairly advanced complications. In order to be eligible, they had to have at least one of the metabolic abnormalities shown here. So diabetes, fasting hyperinsulinemia, or fasting hypertriglyceridemia. But most of them had levels that were well above these criteria. And in fact, among the enrollees with generalized lipodystrophy who participated in studies at the National Institutes of Health in the US, 74% had diabetes, and generally their diabetes was not adequately controlled, with a mean A1C at baseline of 8.6%. Almost 70% had hypertriglyceridemia, and the mean baseline triglycerides was 14.5 millimoles per liter, or about 1,300 milligrams per deciliter. So we asked the question, what is the impact of metreleptin treatment when it is started before these advanced complications of lipodystrophy develop? So our aims and our hypotheses were as follows. We asked, does starting metreleptin prior to the onset of clinically significant metabolic disease alter the natural history of generalized lipodystrophy? Do individuals who begin metreleptin early, meaning prior to onset of clinically significant metabolic disease, compared to those who start late after the development of clinically significant metabolic disease, have better metabolic outcomes? And we hypothesized that starting metreleptin early in the course of generalized lipodystrophy would result in less severe disease progression with respect to metabolic parameters. So this was a single-center retrospective analysis of subjects with congenital and acquired generalized lipodystrophy. We included 65 patients who were all treated with metreleptin, and to be eligible for inclusion in this analysis, they had to have data at baseline prior to metreleptin and at least after 6 months or 12 months of metreleptin treatment. But the majority of them had data over a much more extended period of time, and in fact, we analyzed their data up to 10 years of metreleptin treatment. The outcomes that we looked at included fasting serum insulin, C-peptide, glucose, triglycerides, hemoglobin A1C, 24-hour urine protein excretion, ALT, and liver disease severity. So this table shows the baseline characteristics of the individuals who were included in this study. You can see that the majority of subjects had genetic forms of lipodystrophy, with a minority being acquired. As is typical for most studies in lipodystrophy, most of the patients were female. The median age was in the teenage years, and the majority of patients with genetic forms of lipodystrophy had the AGPAT2 mutation, with a minority having the BSCL2 mutation. So these are some theoretical graphs. This is not the actual data from our study, illustrating what we might expect to see if there is versus is not a difference with respect to early versus late metreleptin treatment for the natural history of lipodystrophy. If you focus your attention first in the graph on the left, we can see that we would define for some outcome, let's say triglycerides, for example, that patients in the late treatment group, by definition, will have higher triglycerides, meaning advanced metabolic disease, compared to those in the early treatment group. If there is a difference with respect to the natural history of these two groups over time with metreleptin treatment, we would expect the curves on the left so that there is a maintained difference in the outcome of interest, such as triglycerides, over the course of years of treatment with metreleptin. On the other hand, if metreleptin gets everyone to the same point for any given metabolic parameter, then these curves are going to come together over time. And this would imply that it doesn't really matter whether you start metreleptin early versus late in the course of that particular metabolic parameter. So how did we define what we meant by early versus late initiation of metreleptin with respect to metabolic disease? We had to define this for each individual outcome because there really were not any patients who had no metabolic disease for any relevant outcome at the time that metreleptin was initiated. So for most of the parameters, we used an upper limit of normal to define the onset of clinically significant metabolic disease. You can see that was the case for fasting triglycerides and glucose. For hemoglobin A1C, we used an ADA target of 7%. And then we also looked at insulin secretion measured as C-peptide and insulin areas under the curve during an oral glucose tolerance test. And for that, we used our A1C cutoff to define early versus late. For urine protein excretion, we used the upper limit of normal of 300 milligrams per 24 hours. And then with respect to our liver outcomes, we looked at ALT as a marker of liver injury and platelets as a marker of hepatic fibrosis. And for both of these, we defined early as patients who had a liver fibrosis score of 0 to 2, and late as patients who had advanced fibrosis at stage 3 to 4. So here we can see the glycemic outcomes. So patients who were defined as having early treatment are in the black line. You can see that they had normal fasting glucose at the beginning of metreleptin treatment, and those in the late group, of course, had elevated fasting glucose prior to metreleptin treatment. And what you'll appreciate is that there's a maintained separation between these two groups over time. And in fact, the early treatment group maintained, on average, 42 milligrams per deciliter lower fasting glucose over time compared to the late group. We see a similar pattern for hemoglobin A1C on the right, where there's maintained separation between the early group in black and the late group in red, such that the early treatment group maintained 1.5% lower hemoglobin A1C over the follow-up duration on metreleptin treatment. This graph illustrates C-peptide and insulin areas under the curve during oral glucose tolerance testing. And just to remind you, we're defining early and late groups based on their A1C, not based on their insulin secretion. So now we see the opposite pattern. Patients who had lower glycemia based on A1C at baseline have higher insulin secretion prior to metreleptin treatment, indicating better beta cell function. And those patients in the early treatment group maintain better beta cell function over time. So to get into the details, at baseline, the early treatment group had almost 60% higher C-peptide A1C prior to metreleptin treatment, and they maintained 33% higher C-peptide secretion over time, with a similar pattern seen for insulin. Here we look at triglycerides. You can see, of course, that triglycerides are higher in the late treatment group compared to the early treatment group. And here there is huge overlap of these confidence intervals because there's just enormous interpatient variability for triglycerides. In this analysis that I'm showing you, we did see ongoing separation between the two groups, such that the early treatment group maintained 92 milligrams per deciliter lower triglycerides over time compared to the late treatment group. But a subsequent analysis that we did that restricted the data to only 10 years did not show this difference, suggesting that early versus late treatment with metreleptin with respect to triglycerides may not significantly alter the natural history of hypertriglyceridemia in patients with generalized lipodystrophy. Here are the data for urine protein excretion. We're seeing the same pattern that we did for the glycemic outcomes, where patients in the early treatment group maintain almost 1 gram per 24 hours lower urine protein excretion over time compared to the late treatment group. Now we're looking at our liver fibrosis and inflammation markers. We can see that patients in the late treatment group in red maintained higher ALT over time and lower platelets over time, suggesting that metreleptin was altering the natural history of liver disease in these patients. So in conclusion, lower hemoglobin A1C and higher areas under the curve for insulin and C-peptide in the early treatment group suggest that there was greater preservation of beta cell function in patients who were treated with metreleptin before they had poor diabetes control. Lower triglycerides and lower urine protein excretion during follow-up in the early group may indicate better control of hypertriglyceridemia and proteinuric nephropathy following early metreleptin treatment. But again, the benefits for triglycerides are really less clear than for urine protein excretion. And finally, the higher ALT and lower platelet counts in late fibrosis groups at baseline and during follow-up suggest that there may be irreversible hepatic fibrosis and hepatocellular injury prior to treatment with metreleptin in the late treatment group. And I'm happy to take any questions.
Thank you, Dr. Brown. Excellent speech. Someone of the audience has a question? Dave.
Hi, Rebecca. Congratulations for your very nice talk. Basically, the advice will be in terms of related to generalized lipodystrophy, as soon as we can start as soon as possible.
So I think that is more clear in patients who have BSCL2 variants causing generalized lipodystrophy because of the hepatic fibrosis that occurs at a very young age in those patients. And I think the evidence is pretty clear that once hepatic fibrosis is quite advanced, that metreleptin may not be able to improve that. And so it's advantageous to start it early. I think we also, from looking at these data, can conclude that there are advantages to starting metreleptin early with respect to preserving beta cell function by reducing that strain on the beta cell from severe insulin resistance. But for triglycerides, I think, again, that probably doesn't matter quite so much when you start metreleptin treatment.
And this will be extended independently to congenital generalized lipodystrophy and also acquired generalized lipodystrophy.
Yes, at least congenital generalized of the AGPAT2 and BSCL2 variants. We did not have any data on CGL3 or 4.
Yeah, but in the case of, I comment that because I have some I'm a bit reluctant, for example, in some cases of acquired generalized lipodystrophy, that they are quite well metabolic, at least from a metabolic point of view, and you have to make a decision to use a very specific drug, and say, well, we are waiting for, because I don't know what will happen in the future. That's is why I have some doubts about that, and some patients in this condition.
Right. So, we didn't have a very large sample size for patients with acquired generalized lipodystrophy. I don't think we would have the statistical power to divide up that subgroup based on early versus late definitions that we used. It's an interesting question that you raise. I think probably one could make some doubts based on these data as to how generalizable our conclusions are to patients with acquired generalized lipodystrophy.
Thank you.
Thank you so much, Dr. Brown. We will continue with the professor.